looks like with the nozzle for ear for removal of foreign body in the ear. So foreign body in the nose, this is a plastic ball in the left nasal cavity. So it is common to see small items, especially in young children, being placed in the ear while playing. So we can also see things like disc batteries in the nasal cavity. So this is a plain radiograph of the head showing a disc battery in the nasal cavity. These are disc batteries that have been recovered from nasal cavity. So in removal of foreign body from the nose, we can use the nasal hook, the nasal forceps. You can use the parent's kiss, suction with a nozzle, or use a Fogarty's catheter. Using the nasal hook, the child or the patient who is the victim of the foreign body should be restrained in an upright position. Um, we can add a few drops of nasal decongestant in the nose and suction in order to visualize the foreign body properly. Then a curved hook, just like the one for the ear, is passed beyond the foreign body and then rotated, and gradually the foreign body is brought out and removed. So this is a picture of the nasal forceps. Now the parent's kiss, or otherwise known as the positive pressure technique, is a technique where the parent blows through the mouth of the child. Usually the parent should inform the child that they are going to give them a kiss so that they can calm them down and they relax for the procedure. Then the parent will form a good seal around the mouth of the child and then blow into the mouth while occluding the unaffected nostril. The expectation is that the foreign body with the pressure should go through the nasopharynx and into the nose to push out the foreign body from the contralateral nostril. The fear for this is usually barotrauma, but it actually has a very low risk of barotrauma. The pressure is usually less than 60 millimeters of mercury, and that's similar to a sneeze. This is what the suction and the nozzle for removal of foreign body from the nose looks like. Then we can also use the Fogarty's catheter. So in using this, you ensure that the balloon is intact. The catheter is placed beyond the foreign body, then the balloon is inflated, and then the catheter is withdrawn. So it's withdrawn through the anterior nostril, and then the foreign body is pulled out. So we'll move to the upper airway. Foreign bodies in the throat are commoner in young children because they lack molars for proper grinding of food. They tend to be running or playing at the time of aspiration. They tend to put objects in their mouth more frequently, as it is a normal developmental curiosity. They also lack coordination of swallowing and glottic closure. In adults, it can happen accidentally with a cough or a sneeze when something is in the mouth. It may also occur during sleep or while in alcohol intoxication or with extraction of teeth during local or general anesthesia. Mentally retarded people are rare victims. Removal of foreign body from the oral cavity and oropharynx, usually the tonsil, in the oral cavity and the oropharynx, the tonsil is the usual site of impaction. So we can have a fish bone impacted in the tonsil. In the esophagus, coins are common foreign bodies in the children, while dentures are commoner in adults. There are about 5 constrictions in the esophagus where a foreign body can be lodged. These are the cricopharyngeus, which is the upper esophageal sphincter. Majority of foreign bodies in the esophagus are lodged in this region. Then about the midpoint of the esophagus, we have the constriction created by the arc of the aorta. Then the left constriction created by the left main bronchus, that by the diaphragm as well. Also, these are also points where foreign bodies can be lodged. Then the gastroesophageal junction. Food items are majorly aspirated commonly. Not or small food particles are the most frequently aspirated food. In the airway, however, after foreign body aspiration occurs, the foreign body can settle in three anatomic sites, either the larynx, the trachea, or the bronchus. In the bronchus, the right main bronchus is the most common site where foreign bodies are found because one, it is bigger, and then it also has a straighter angle of origin from the trachea. Laryngeal foreign bodies usually cause complete or partial airway obstruction. You can see the larynx here encompassing the epiglottis, the supraglottis, the vocal cord, the glottis, and the subglottis. Foreign bodies aspirated in the throat can cause symptoms such as cough, hoarseness, dyspnea, odynophagia, or dysphagia. They can also cause upper airway obstruction. Here we may have aphonia, which is inability to talk when we have a cough, this which indicates a complete upper airway obstruction. We could also have a stridor, which is a musical note heard majorly during inspiration, and this indicates an incomplete upper airway obstruction. If it's a wheeze, it usually indicates an incomplete lower airway obstruction. And then when you have loss of breath sounds, that indicates a complete lower airway obstruction. Removal of foreign body from the oral or oropharyngeal from the oral cavity can be done with the use of the forceps, or it can be suctioned with a nozzle. In the esophagus, most foreign bodies can pass through the GI tract without incidence. However, 10 to 20% will need endoscopic removal. So if the okay, so you can use the Foley's catheter in removal of foreign bodies from the and forceps can be used. In the larynx, the laryngoscope can be used for removal of foreign body. So this is what a fish tongue in the tonsil looks like, and it can be removed with the use of the tonsil forceps. This is a plain radiograph of the chest showing a coin in the esophagus. So it's an anterior-posterior chest radiograph, and the coin here appears as a circular disc, which is called emphase. In the lateral chest radiograph, the coin appears as a thick line on edge, which is called on edge. But we should note that in the trachea, if this coin were to be in the trachea, it will be the opposite, meaning that on anterior posterior chest radiograph, it will have the on edge appearance, and then on the lateral chest radiograph, it will have the on face appearance. This is a denture that has been recovered in. So the clinical presentation of these foreign bodies actually depends on the size, the shape, the location of the body where it is, and how long the foreign body has been retained. In the ear, it is largely asymptomatic. However, it could cause pain, hearing loss, tinnitus, and other noises. In the nose, it's also largely asymptomatic, but it could also cause rhinorrhea, unilateral foul-smelling discharge, and epistaxis. In the throat, it could cause pain and discomfort, dysphagia, and difficulty in breathing. Foreign bodies in the tracheobronchial tree can cause episodes of coughing, intermittent or continuous dyspnea, cyanosis, pain, and intermittent hoarseness. If the foreign body is still on the tracheobronchial tree, if the foreign body is retained for a longer period of time, it can lead to accumulation of secretions, tracheitis or bronchitis with edema, swelling and granulations, bleeding, partial obstruction of the lower airway or emphysema, or atelectasis. So now, in making a diagnosis of a foreign body, first you want to take a history from this patient. You want to know the age of the patient, which foreign body they have ingested, how long it has been there, and find out the symptoms that the patient has, bearing in mind that it can be asymptomatic. However, you should ask for other symptoms like cough, and pain in the ear discharge, ringing, hearing loss, and all of that. You also examine them in a comfortable position, because majority of the patients implicated in these are children. So you make sure that they are comfortable, otherwise they will be unable to cooperate with you, and you will not be able to examine properly, or even remove the foreign body. Certain investigations can be done. You can do an anterior rhinoscopy, which is an examination of the nasal septum with the nasal speculum. You can do an automicroscopy, which is looking at the tympanic membrane or the external auditory canal with the surgical microscope. Then fluoroscopy, if it is available, can be done as well. This uses continuous beam of X-rays, which gives you real-time imaging of the object. So if the object in the canal is moving, you actually see it moving. Other X-rays that can be done are plain X-ray of the head and neck, chest X-ray, abdominal X-ray. Because if, for instance, a patient ingests something like a coin, for instance, that we saw earlier in the esophagus, and it has passed, at the time of checking the chest X-ray, it has already passed the pylorus. It will no longer be visible on the chest X-ray. Then you now be able to see it on the abdominal X-ray. In this case, majority of cases that have been passed already, they are left to go through the intestine, expecting that the patients will pass it out through the feces. So sometimes serial abdominal X-rays can be done in order to monitor the movement through the intestine. However, if the foreign object has not been passed after about 3 days, then there may be need for surgical intervention, so that you don't end up with intestinal obstruction or perforation or any other complication. CT scans as well can be used. So talking about upper airway obstruction, in mild obstruction, you can have cough, hoarse voice. Usually there's no respiratory distress. In moderate obstruction, you can have a stridor with agitation, moderate respiratory distress evidenced by mild intercostal and subcostal retractions, moderate tachypnea. In severe obstruction, you can have stridor, severe respiratory distress evidenced by severe intercostal and subcostal retractions, nasal flaring, substernal retractions, and severe tachypnea. Then in imminent complete obstruction, you could have severe respiratory distress with cyanosis, oxygen saturation less than 90%, agitation or lethargy, tachycardia, or respiratory distress, which can be followed by cardiac arrest. If this happens, you want to perform an immediate maneuver. Here, we're going to be talking about the Helmholtz maneuver. So it is usually done only if the patient cannot speak, talk, or cough, or cry, or breathe. Usually it indicates total obstruction of the upper airway. So you have the symptoms: patient cannot speak or talk or cough, and then plus the choking sign. So sometimes you may have these patients clutching onto their neck with both hands, clutching onto their throat. So if that happens, you need to immediately swing into action. You need to administer the Helmholtz maneuver in order to relieve the obstruction. So for children over 1 year and adults, the technique is the same. But in infants under 1 year of age, you give a combination of 5 back blows and 5 chest thrusts. I'm going to be explaining that in a few minutes. So let's start with the adults or children greater than 1 year of age. So you support the person's chest with one hand and lean the person forward so that the object blocking the airway can exit the mouth instead of going further down the throat. Then you administer 5 forceful blows between the person's shoulder blades with the heel of your hand. Then you need to pause after each blow to see if the blockage has cleared. So you stand behind the person and you can stand slightly off to one side. If you're right-handed, you can stand to the left. If you're left-handed, you can stand to the right and administer the blow. So you give 5 back blows. If the object doesn't come out, then you go ahead to administer abdominal thrust. So you stand behind the choking victim, put your arms around the victim's waist and lean him or her forward. Then you make a fist with one hand and place it directly above the victim's umbilicus with the thumb side of the fisted hand on the above the umbilicus. You place the other hand on top of the first hand. Then you thrust both hands backwards and upwards into the the victim's abdomen, backwards and upwards, thrusting it about 5 times. So make sure after each thrust, you check to see if the blockage is gone. So you administer 5 back blows and then 5 abdominal thrusts, each time checking to see if the blockage or the object has been dislodged from the person's airway. However, you should stop if this victim loses consciousness. So this is a summary of what I'm talking about. So on the left, you can see the Helmich maneuver being administered on the victim. On the right, you can see it being administered on the child. So the child should be placed stomach down across the administer's forearm. Then while your hand is supporting the jaw and the head, then you give 5 blows on the child's back, five thumbs on the child's back with the heel of your hand. After administering the 5 thumbs, you flip the child over and administer with 2 fingers. You administer 2 chest thrusts. So with 2 fingers, you administer 5 chest thrusts. So just below the nipple line, you place your finger there in the midline and administer 5 chest thrusts. So you alternate 5 back blows and 5 chest thrusts until the object is dislodged from the airway. If the patient is alone, if the victim is alone, if somebody ever has such is choking and finds himself alone with no help, you can the Helmich maneuver can be administered on the individual by himself. So you just make a fist with one hand, grasp it with the other hand, lean over a chair or a countertop, and drive the fist inwards and upwards towards yourself. So what if this patient is obese or pregnant? You need to place your hands higher than where we have described. So higher, place it at the base of the breastbone, just where the ribs join, and press hard into the chest with quick thrusts. Here, no upward thrust will be possible. So you repeat until the patient stops choking and the blockage is dislodged, or if the patient falls unconscious. So if you are able, if the patient victim is able to, you can ask them to spit out the foreign body and breathe without difficulty. But however, if they are unable to, you can look in the mouth and do a sweep with your finger. But you should only sweep if you see an object. Otherwise, you can stand the risk of pushing the object further down into the throat. Make sure that the patient resumes spontaneous breathing, coughing or crying or talking. However, if the patient loses consciousness, you lie the patient on a flat surface and administer the CPR and ventilate. You could also do the tracheostomy if you're unable to ventilate. Also, you could monitor the patient's saturation, except it's in mild obstruction. So you administer oxygen when the saturation is less than 90%. You maintain SpO2 between 94 to 98%. If this patient has cyanosis or respiratory distress, you need to administer oxygen. If you do not have a pulse oximeter available, then you can administer oxygen at 5 liters per minute to relieve hypoxia and improve respiration. You should also hospitalize in the intensive care unit if you have danger signs like the cyanosis, saturation less than 90%, or severe respiratory distress. Monitor the patient's mental status, the heart rate, the respiratory rate, the oxygen saturation, and severity of obstruction. Then also maintain hydration, adequate hydration by mouth if possible. if not possible by intravenous route. Other adjunctive treatment measures include use of antibiotics, chest physiotherapy after the foreign body has been removed. Then patients can be discharged when they are fully awake or when, and breathing comfortably without the need for supplemental oxygen. Operative treatment may be, you may need to have operative treatment done if there has been perforation, for instance, of a foreign body in the abdomen has probably perforated the intestines or even in the airway. You can do a removal under mild sedation, or you can do an examination under anesthesia. This is especially done in children where they are so agitated and unable to cooperate with you. Other operative measures that can be done are laryngoscopy with a flexible or rigid laryngoscope, oesophageoscopy, bronchoscopy, or tracheotomy. Complications are usually the result of delay in diagnosis or when there's delay in removal more than 24 hours. Complications include bruises of the tympanic membrane, the nasal septum, the esophagus, lacerations, perforations, pneumonia, atelectasis. Bleeding can occur from granulation tissue that is surrounding a foreign body or when there's erosion into a major blood vessel. Pneumothorax can occur, pneumomediastinum, epistaxis, or respiratory failure can occur. In conclusion, foreign body in the ENT are common presentations in the outpatient department and emergency room. Some of these could be serious and even life-threatening. Accurate initial assessment and diagnosis of life-threatening presentation is key to treatment outcome. Health education to the patient and his or her family is integral to the management of these cases. These are my references. Thank you.
All right, thank you very much. Thank you very much, Dr. Akhigbe. Okay, so we'll attempt the questions now.
Okay.
Go ahead.
So, question 1. In the oral cavity and oropharynx, the usual site of foreign body impaction is 1, the vallecula, B, the tonsils, C, the uvula, D, the base of the tongue, E, all of the above.
Answer. The tonsils. all right, tonsils, the tonsils. Question 2. Yeah.
The constrictions in the esophagus includes the following except A, cricopharyngeus, B, arc of aorta, C, right main bronchus, D, gastroesophageal junction, and E, none of the above.
None of the above. None of the above.
None of the above. Good.
None of the above.
C is C. It's not right, it's left.
It's left main bronchus.
Yeah, left.
Aha.
Question 3. In airway obstruction, the following signs are elicited except A, aphonia, B, stridor, C, wheeze, D, loss of breath sounds, E, none of the above.
E.
None of the above. Correct.
None of the above.
None of the above.
Okay. All right.
The following are true of treatment of foreign body in ENT. A, use of antibiotics. B, use of cathartics. C, oxygen therapy. So we're supposed to say true or false for each option.
Okay, this is the multi-choice. Okay.
Yes. A, antibiotics.
True.
True.
Answer now, resident.
You guys should answer.
True.
It's true now. Like if
It's
you have
true.
for that nose that has smelling, foul smelling, this
Yes.
section.
Yeah.
Yes.
Insects as well too. Chiefs.
Yes. True. B, cathartics.
Yes.
Cathartics are
Examples
purgatives.
of cathartics are what?
Purgatives.
Yeah, answer now.
So it's false. You should not use purgative because you could actually worsen the situation. It could cause a perforation and complicate the situation. C, oxygen therapy.
True.
True.
True. D, proteolytic enzymes.
False.
False. E, Helmich maneuver.
True.
True.
Answer true or false. Foreign bodies in the ENT tend to be largely asymptomatic.
False.
False.
It's true.
False.
It's true that it's automatic.
Asymptomatic.
See, number
That's
6.
why on the second.
A foreign body aspirated in the trachea on anterior posterior view of the plain radiograph appears on edge.
True.
Actually, it's on edge.
True.
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 Okay, so is it true?
It's
Yes.
true. It's true.
True.
The parent's kiss, positive pressure technique, is used to dislodge foreign body from the ear.
False.
False.
Foreign body in the ear are mostly seen in the ear canal.
True.
True.
It's true. Bronchial foreign bodies. Number 9. Bronchial foreign bodies are mostly seen in the right main bronchus.
False. Oh, wait.
Left.
True. It's false.
True.
It's true.
True.
True. Okay. It's true.
Right main bronchus.
Yeah.
Left is true. It's false.
Right.
Okay. End of slide.
Nice.
All right, wonderful. Let's all clap for Dr. Akhigbe. Yeah. Nice one. Wonderful presentation. Good.
Very nice.
Carried
Thank
everyone
you.
along well. And
Pictures.
the slides were clear, the pictures were interactive. Very
To
good,
the
very
extent
good.
that my
presentation.
daughter learned.
She has also learned something. I mean. That's good. So you can stop sharing your slides now. Why am I showing on the screen? Okay. All right. So thank you so much. Thank you so much, Dr. Akhigbe. So if
Thank
you
you,
can see your chat window, there are some questions there for you.
Where is this laptop coming from?
Yes, Dr. Idabo asked about, okay, now it will be common because of full holidays like COVID lockdown.
No, when she said during the
Yes,
holidays.
yes.
Now, possible holiday. So
True.
we're expected to have been seeing it, have you?
Yes. More cases should arise from this because they are home, children are playing, all sorts of things, beads and all that at home. So we can easily lodge in their nostrils, their ear, or even their esophagus. So very true, Chief. Thank you very much. So how is tick sputum a foreign body, Dr. Akhigbe?
It's a foreign body because, like the definition, is when something is where it's not supposed to be. So that thick sputum is not a normal part of the anatomy of that part of the body. So that's why it's a foreign, because it can even cause an obstruction.
Tick sputum. So
Especially
normally your
if it's in
esophagus,
the
you don't have
airway.
sputum.
Especially if it's in the airway.
Yes, I can understand. Even the airway, you mean you don't have secretions there?
You have secretions, but that's why you qualify it as thick, because it's now.
So if you have secretions there, is that not the normal place they're supposed to be, and it has thickened? So does it qualify to be a foreign body?
It has thickened, so it has now constituted a foreign body.
I'm just following your definition.
Than normal.
I'll follow your definition. You said anything found where it's not supposed to be in the ear, the nose, and the throat. So if it's in the esophagus, for example, there's usually secretions there, sputum and all that.
Yes, there are secretions, but they are not like thick. They are just.
But they are there normally. It's just the thickness now.
The thickness.
So does it follow with your definition?
Pathology.
It does, Chief.
Hey, no, I'm just trying to tease us a little anyway. So, fine. So let's go to the next presentation. Have you heard of steakhouse syndrome? The next question by Dr. Idabo too.
No, I have not.
Steakhouse. So does any of the residents know about steakhouse syndrome?
Who has heard of it?
Okay, that's when you eat, when there's an impaction or obstruction in the esophagus when you eat food, especially like meatballs or steak.
Yes.
So Incidentally, it's something that happened to me because I was rushing meat. I didn't chew the meat well. So commonly when you're eating steak and you don't chew well, and you swallow it. I don't know if that's happened to anybody.
We
You swallow it,
never chopstick.
it can cause
It gets stuck.
keep the foreign body. So you have severe pain. It can even impact your it can prevent you from breathing well even. Of course, my own is that part, but that's what led me to reading about steakhouse syndrome. Because for days, my lower esophagus, I was feeling pain there. And I thought that maybe I should go and see Dr. Amodu. When I now read
it can even cause ulcer depending on the duration it will stay.
And sometimes if the foreign body is left, if the meat or the bone or the lump of food is left there for too long, it can erode.
Yes. True. Thank you very much, Chief Idabo. Then the next question is that, okay, how is the parents' case removing the foreign body in the nose? Okay, I think you later explained that. Initially, in a previous slide, you had just mentioned it. There was no explanation.
And she gave a picture.
Yes. Very good. Analyze it properly. So, Dr. Mimi asked for pre-part one. Okay, for pre-part one doctors, note the tool used to remove foreign body. You mentioned a few tools, but which was the one we usually use around? Dr. Ireme, you know the common tool we use to remove foreign body? The common one. Okay, like for example, the ear. Let me be more specific now.
The ear.
For the ear.
I would assume the oral hook.
Okay. Dr. Iweha, Dr. Iweha was going to say, because it was in our exam, we had a station, an OSCE station for removal of foreign body in the ear. So all these tools will be there, but crocodile forceps is the right one to use. And they're going to watch you how you're going to remove with that tool, how to pick out that foreign body in the mannequin's ear. So it's very important, especially for residents. This is something that was in my exam with Dr. Uche. So it's very, very important. We should be very much aware of it. Know how to identify it, the angulation and all that. I think you posted a picture with the crocodile forceps. Did you?
Yes.
Yes. It just opens at the tip like that, just at the tip. Very important.
Not holding like scissors. It has a very funny.
Yeah, there's a way. Yeah, it has a funny shape. You have to learn how to hold it because they'll watch you. All those things has its scores. So for pre-part one people, let's take note of that. Then you also need to know how to couple and handle the otoscope, the oroscope, and other instruments. It frequently comes out in OSCE or oral session. You have to know the parts of the instrument. Yeah, so the same thing like we just said now in OSCE. Most of these instruments, they are not things we use commonly, but ideally, if we want to following family medicine and all that, we should have our diagnosis set at our consulting table. So we should be able to know how to couple it appropriately. So, once you get to an OSCE station, they are looking at apart from the mannerism of the patient, you want to see how you use and couple this instrument, because most times they are not coupled. You include the batteries, you do the settings, you ensure the light is on and all that. So they want you to see if you've not used it before, it will be very clear. You'll be confused and just, So that's, we can visit Dr. Amodu's clinic and Kofi Bukwe's clinic to see and get familiarize ourselves with this instrument. Then, okay, there's another question. What do you do when Heimlich maneuver fails?
Wicked question.
If the patient becomes unconscious, then you need to commence CPR immediately. Okay. And then, then you can hospitalize the patient, administer, manage in ICU, administer
before
oxygen,
you go to hospital.
Yes, good. Dr. Nome just said something. Now, before you get to the hospital, what are you going to do?
Always.
What else can you do?
What site?
Okay, I'm apart from administering CPR. You can place the patient in lateral position.
And this small thing.
No.
Now start finding them.
Okay, any other person? I know what else to do if your Heimlich maneuver fails.
No, going about it the wrong way. So let me go.
Dr. Nome,
Yes.
do you have anything in
Tracheostomy.
mind?
Tracheostomy.
Yes. Tracheostomy, you open, you have to just open up.
Yeah, thank you.
Are you saying, it's like we have a, did you people invite one of the ENT to join us?
Dr. Amodu, I was supposed to tell, but it was a little late.
Because I'm seeing her, CPR, where's the obstruction? Can you go below? In answer to that question. You understand?
Okay, no, that's, I think it's Dr. Ebutana is the Omega, yeah. Okay.
This resident, Dr. Nome said tracheostomy. I hope people know what she means, how to put in the tube. People are always so quiet. If you people have your South African manual, some of these procedures are there.
Very simple procedures.
You really need to cram them. You really need to know them. Because when you get to the exam station, like Dr. Ehi said, nobody talks to you. You just move in for the 7 minutes you're there doing. If you do nonsense, they don't send you to. When you leave, you know you've done nonsense. If you're doing well, they'll just be marking for you. So it is very important.
Yeah.
Very, very important.
Thank you, Chief Uche. Thank you, Chief Uche. Then even if you find yourself in an environment where you don't have the tracheostomy tube and all that, there are some things you can just improvise. Like what? You know?
So if here to here is 11, here to here is 4.
Dr. Akhigbe, do you know anything you can improvise if you don't have the tracheostomy tube?
I've seen.
Sorry, I didn't hear you.
Pen.
What?
Pen.
Yes, pen. That chamber will be big. That's your normal big Bible. That you can remove the ink tube inside and use that pen, that chamber. Can use it temporarily as your tracheostomy tube, depending when you can get the patient to the hospital to have a proper tracheostomy and the tube inserted. Okay. So Y60 rings, right of main broken. Why right main broken? Okay. Okay, you already explained that. Why is coin edge? I don't understand. Why is 60? And that is coin.
You know, she was
edge.
saying something about that anterior posterior position that you see the coin on the edge, then the other one is surface, Abi. And surface
yes,
also.
Yes,
so
okay. Okay. Wonderful. Then Dr. Taiwo asked if you successfully remove a foreign body from an orifice. You should, it's a contribution. You should try and look in all other orifices around. You might find some other ones. It may not just be one foreign body that is lodged in the airway or throat or ear canal of the patient. You have to look at all other possible orifices around that area to see if you have smaller ones, especially that have gone deeper than the bigger one. Thank you very much, sir. Then, okay, Dr. Ebuta posted a publication. Okay, he said we'll share it on WhatsApp. So, okay, he also asked, what if you can't do tracheostomy? There's another procedure called, procedure below the cricoid or something. Needling? Okay, then Dr. Nafio answered cricothyrotomy. Cricothyrotomy. So that's just below the cricoid cartilage. That's where you perform that. Then Dr. Taiwo talked about CPR being a mega station in Badon. So we should know it very well. Many candidates had a lot of problems. One of us was told by the examiner that he has killed my patient. Oh my God. Those OSCE stations can be very dramatic. So most of these common things, CPR, very compulsory. Need to get used to it, know about it. Dr. Elisi also posted it now, know about the intubation. And Dr. Akhigbe, have you intubated today?
I did. I did not take break today.
No, she's around. She's around. I think she was trying to say something.
I just
Okay, maybe network is fluctuating or something. So Dr. Nafi also talked. What? Yeah, Dr. Nafi also talked about when all those measures fail, please call for help. Call the anesthetist and the ENT surgeon to take over the patient's breathing and then perform a bronchoscopy to take out the foreign body.
When do you refer? So that takes us to the question of when do you refer?
When do you refer?
When it has gone beyond.
Can you hear me?
Yes, we can hear you, IJ.
You intubated today?
Network is still.
She will intubate, don't worry.
She will intubate. Yeah, she can't dodge it. She can't miss it. Mm-hmm. For them to, for Dr. Akhigbe to say she's doing well, that means very soon she will intubate.
We'll see what that's the most important.
All right, thank you very much, everyone. Do we have any other contribution or question from anyone? All right, so in the absence of any other thing, it's past 9, 5 minutes past 9. Thank you, everyone, for the participation. Thank you, Dr. Akhigbe. Done well. So I'll be ending the meeting now. Let's all have a good night.